Hi, thank you so much, Teresa, for being here today and taking the time to be interviewed. We're so excited to learn from your experiences. So I'll go ahead and start us off. What is your title?
I Today I am an associate professor at the University of Utah College of Nursing, and I'm also the co-lead of the Utah Action Coalition.
Right. Those sound busy. So our second question, please describe your nursing work and career and take us through your career trajectory that landed you in your current position.
Thanks, Angie. I've been thinking about that question this morning. My career trajectory, uh, accidental. Words I would use to describe my career trajectory are accidental, mentor based, community driven, and uh, lucky and intentional. How's that? My first job out of nursing school, I was a single mom. I was 22 years old, living in, a little apartment. I had no idea what childcare, a bit overwhelmed by life. And I'm looking in the newspaper. Yes, looking in the newspaper for nursing jobs. That's how you did it in my day. I'm going down the column, and there's this little tiny ad for the Salt Lake Indian Health Center. They're looking for a clinic nurse. And I just think, oh, that sounds really cool. I could do that. Clinics are open Monday through 8 to 5. I could figure out childcare. I could make this work. It turned out to be an amazing choice for me. My career has always been, as a nurse, has always been in the community. I've worked in at the Indian Health Center for a couple of years. I've done home care, I've done long-term care, I've done some consulting. And then after a series of accidents and companies going broke and economy busts and various things and a mentor relationship, I landed at the Utah Department of Health, which is a huge agency of 1,500 employees, covering the public health needs of Utahns from um, uh, uh, frontier counties to urban counties to metropolitan districts, a huge range of population needs. And I found my people. It was the place for me to be. I spent almost 20 years there. Did as much as I could do at the Department of Health. I started out as a nurse consultant in the TB control program, and I ended my career as the deputy director and the state public health nursing director. And I, I did everything I could do short of being the executive director. I do have a little bit of wounding from hitting that glass ceiling. I hit it kind of hard, but that happens. I moved on to Intermountain Healthcare, where I worked for 3 years, working on their care management processes, really trying to establish the high complexity work that they ended up doing. Integrating community health workers into the system, trying to take some of those public health principles that are so grounded in my practice and applying them in a major health system. Turns out working in a major health system wasn't for me. I landed back at the College of Nursing, and I landed at the College of Nursing because of a mentor. The dean at the time needed help with an advocacy effort, and I spent a whole bunch of time at the Department of Health doing advocacy work and working with state legislators to make policy change. And she needed help with that, and she was describing it, and I said, Trish, I could help you with that. At the time, I was unemployed. It was blissful to be unemployed for 3 months, I have to say. Only time in my career I ever did that. So I left Intermountain, joined the College of Nursing, and haven't looked back. I became the co-lead of the Utah Action Coalition, which is an effort to log, track, chart, lead Utah's response to the, I keep it here at my right in front of me, the Future of Nursing report. We're working on the 2020 to 2030 objectives right now. And that has opened up all kinds of new relationships and opportunities for me. So my career has always been in the community.
That is so great. And I love that you talked about that you joined it because it was meeting a family need as a single mom.
Yeah.
And I love that you talked about how you're able to grow in nursing. And I think that's what's so cool about nursing is there's so many different opportunities, and it gives us room to grow and be our best selves. And so thank you for sharing that. I appreciate it.
I use my nursing brain every single day of my career. Every single day. Yeah.
Yeah.
I think that segues really nicely into question 3. How would you describe your leadership? I know you mentioned the head injury from the glass ceiling. And you've had a multitude of different work environments, so I think that'd be interesting to hear how your leadership perhaps started and how it's digressed over time, seeing each of these environments, specifically in nursing in the healthcare field.
Yeah, nurses are leaders. There are special skills that nurse leaders need to have, but there isn't ever a time in one's nursing career when you aren't pulling on the strings of leadership and integrating that into your practice. You're a bedside nurse leading a patient back to health or to a better health place where they started with. You're in the community. Anyway, I can go on and on about that, but there is that fundamental skill that all of us get in our nursing education to know that we have a leadership responsibility and accountability. So it's always been a part of my practice. I remember early in my career, my dream job was to be the director of nursing in a long-term care center because I love working with the elderly. They seemed like an underserved population. Turns out that's a big clue to what I like to do in my practice is focus on underserved populations. And it was my dream job. I tried it for a while. Yeah, it was okay. Public health was better for me. As a leader, I started, I don't know, probably, again, a little bit accidental. You land in positions and you're like, okay, people, I guess we'll figure out how to do this. The farther into my career, once I earned my master's degree in nursing leadership, I kind of realized, no, I really do have a style. I have a philosophy. I have a way of leading people. And I lean into servant leadership and also into authentic leadership styles. That's where I kind of can't help myself. You know, I'm a rather authentic. I never play poker. You can always tell what I'm thinking, and I think that helps build teams and bring people together. My other leadership philosophy is and style is that if it's not fun, I'm not going to do it. Now that doesn't mean I'm not going to work hard. And it doesn't mean that I might be doing something that's really hard to do, like passing tobacco legislation or trying to regulate nursing practice or trying to help change the way that we work with preceptors in our state. That, you know, there are things that I do that are really hard, but at the end of the day, I had fun doing it. And that's an important thing for me.
Thank you. And I love that because we spend so much of our life in work. And I think it's a privilege to get to choose what we do. I feel very privileged to choose where I am, but to have fun and to love what you're doing goes a long ways. And I think patients in our community can feel that too.
Yeah, it's that there's a lot of talk about finding joy. You know, that's the fourth arm of the we had the triple aim for a while, and now we have the quadruple aim of trying to find joy in our practice. And for me, that's always been a foundational thing. Is if this isn't fun, then we either have to change what we're doing or I'm not doing this anymore.
Love that. Thank you for sharing. So I guess currently, what specific issues in nursing and healthcare do you identify and like address the most right now?
For nursing, we can, there are always things right here in nursing that we're struggling with, whether it be baccalaureate level of entry to practice, educating enough nurses, trying to figure out the perfect staffing pattern, trying to get nurses in all the places in the communities that we need to be. The thing that sticks in my mind about nursing, and an issue not only we have to grapple with as a profession, but healthcare has to grapple with, is violence in our work. I don't think any of us ever expected to go into nursing and to think about being hit or spat on or shoved or yelled at by patients and families. So and that's that level of violence in our work is deeply troubling to me. And I think we have to label it, and I think we have to talk about it a whole lot more than we do. I am thrilled that in our state we were able to get some legislation passed kind of in the middle of the pandemic to protect healthcare workers, but it doesn't get reported enough. We don't take advantage of the laws to really tell people, look, you're coming to me for help. You don't get to treat me that way. And it doesn't, particularly we have to reach out and protect our Black and brown brothers and sisters who do this work with us, and to step in and to be a part of the solution in that work. But the amount of violence surprises people, catches them off guard. It isn't that we aren't teaching people how to deal with it in the education system. It's that it's occurring in our society, and it's kind of bleeding into healthcare. And it's deeply troubling to me when we look at the research about why people leave nursing early in their careers. A big chunk of it is because of the violence that they're experiencing.
Thank you. So that being said, are there any, either that or other relatable gaps in research that you'd like to address?
Well, nurses cannot be public facing enough. So I would say a gap in our work and in our public perception. So, okay, we have this amazing thing called being the most trusted profession. We've been the most trusted profession for 189 years. And what good is it doing us? What does it mean? How are we leveraging that to help the profession and also to help the public be healthier? If people trust us and they listen to us and they come to us in their hour of need, why are we not leveraging that and being much more proactive about putting our voice out there in public? There's some early, well, I wouldn't say early. There's a small niche of nurse researchers who look at this, and nurses, the perception of nurses in the media. Diana Mason does some amazing work in this area, and I'm always intrigued whenever she publishes. It's on my I have an RSS feed that comes across. Diana Mason published something. Okay, run to it. There's a huge gap in our public-facing work. I work really hard to teach other people how to write op-eds and letters to the editor. We need to be in the media. We need to put ourselves out there. We need to project our opinions. It's a piece of that, grabbing hold of that piece of that leadership that we really need to step forward. I'm thrilled that people listen to our physician colleagues, and they should also be listening to us, and they should be listening to the physical therapists and all the other professions. We need to step forward in that area and need to understand why nurses don't do that.
Thank you. And I'm trying to word this, how we can relate that, if it relates at all to current state and national policy priorities.
Oh gosh, it's huge. It's huge. Part of stepping into the public facing arena is also stepping up for in the advocacy and policy world. And we have to think about policy in big P and little p kinds of ways. Little p policy is that policy in the workplace about, do I really get my 30-minute lunch? Do I really get a chance to sit down and put my feet up for 30 minutes and take a break? Or, can I take my leave when I want to take my leave? What if I don't want to work 12-hour shifts? What are the options? What policies can we put in place? What can we do to help the nursing workforce, but also what can we do to help our patients receive better care from us? And that's a piece that we really need to work on, is advancing the profession by addressing the public's health. It's a tricky message. We spend a lot of time talking about ourselves and not necessarily about what we can do and how we can better help the public. And being engaged in policy work is so important. It doesn't mean that you have to march yourself up to the Hill and testify. It means you need to follow a bill. You need to know your legislator. You need to know your city council person. You need to know your school board person. Engaging in that work is really, really important. My experience is that when I walk up to a legislator or a council person, a county council person, or someone and say, I'm Teresa Garrett, I'm a nurse, and I'm here to talk to you about X, I generally can't get to what I'm there to talk to them about before they say, oh my gosh, I love nurses. It's so nice to meet you. My sister's a nurse. My wife is a nurse. My next door neighbor's second cousin, 3 times removed, has been trying to get into nursing school for 6 months. How come he's having such a hard time getting, policymakers are really interested in the nursing profession. They realize our worth and our value, and we need to step up and step into that, because we don't have to tell them too much of a story, because they understand our story, because our story is their story. So there's a lot of work to be done in the policy world. In the big P policy world, there's going to be so much over the next 4 years, depending on who ends up being our Health and Human Services cabinet secretary. We could have immunization policy issues. We could have health coverage, insurance coverage issues. There's going to be a lot for us to engage in to help the populations we care about be healthier.
It was very well said. And I agree. I was totally surprised. Last year, I had the privilege of being up on the Hill for a summit, and every representative in their team immediately off the bat was the same thing. Oh, I'm a nurse, and thank you. It was humbling. So I can think of 100 things just off of what you've said so far. Your immediate response to this is, what will be better in nursing and healthcare? Or I suppose because you've said so many things that I think will make it better, what from your research and leadership are you most proud of that betters nursing and healthcare? Has or will, that you're working on currently?
Oh, I don't like to think back, because the list of things that I've worked on is kind of long, and not all of it's been a success. So, trying to think forward. I am, the work that we're doing with the Action Coalition right now is really pretty exciting. We're trying to work on improving, eliminating racism in nursing education. Huge task, huge, big thing. We call it the wall of well-meaning white women. And here's the scenario. A person comes to a college of nursing, a nursing program, and it doesn't matter if you're in a private program or you're in a state university or a community college. You walk into that program, and there are 8 very well-meaning white women who want to help you advance your career. The diversity of nursing faculty is abysmal, and it impacts our ability to improve people's health because we don't match our nursing workforce doesn't match the diversity of the population we're trying to care for, and we're even worse in nursing education in terms of what our faculty look like. So the work that we're doing with the Action Coalition is really to help that wall of well-meaning white women understand the issues that are happening in their classrooms. We have we're getting ready to run it for the second time. We did a pilot project last spring. We had 15 people from across the state of Utah and across diverse education environments learn about how to handle things that happen around racism in the classroom. And it was amazing and wonderful. And we're going to repeat it again this spring. We're going to add in public health faculty because they have the same issues that we have. So we're really trying to, I'm really excited about that work and hoping that work continues to get funded and move along. It's outside of the university work that I do. So it's, we're able to do it because in Utah we have anti-diversity, equity, and inclusion legislation that was passed and has had a big impact on us. So we're trying to help people adapt to that and give them some skills to improve belonging and success in their classrooms and give them the language that they need and the skills they need to deal with that. So I'm pretty excited about that work.
Yes, thank you for sharing. That's well said. And I was new to Utah, but quite disappointed on House Bill 261. And I think it will be really interesting to see how leaders like yourself in academia that's supported publicly find loopholes. I don't know if that's the opportunities to continue to serve those populations despite this new verbiage. So that being said, oh, sorry.
Fortunately, in nursing, we get to lean into our values. And our values and our ethics say we care for all populations. We have to have the skills to be able to care for all populations. So that requires us to be culturally humble and understand the impact of language. And none of that requires the words diversity, equity, inclusion. It's a whole lot easier if we can say those words. But our values, I loved our dean said pretty early on, she said, we will follow the law and we will not compromise our values. And I have just really just put that in my heart and hung on to that. So knowing that, okay, we will still be nurses. And at the end of the day, we will still be nurses, and nurses care about all populations.
That's very well said. Thank you. So how do you see this translating to local, state, and national policies?
Well, we have lots of work to do. From a I might probably want to move off of the diversity work, because the other work that I do is around the nursing workforce and trying to look at issues within the nursing workforce and how can we, what can we do to help make all of that easier? We know we're going to hit a pretty big cliff very shortly. Actually, we're probably starting to tumble off the cliff in terms of the last of the baby boomers beginning to retire. That's going to leave a huge gap in knowledge in the health systems. We're already beginning to kind of feel it because of the pandemic changes with the number of novice nurses in the workforce. So what do we need to do about that? What do we need to put in place to build up nursing education systems so that we can continually respond? So I've been a nurse for 40 plus years, and we have always talked about a workforce shortage. I'd love to change that language, and I'd love to flip it to talk about, our population isn't healthy because we don't have enough nurses in the population. We know that when you have more nurses in the population, people are healthier. So how can we flip this conversation? How can we turn it? And the other really big issue in nursing education is preceptors. Burnout, novice nurses, you name it. What can we do from a policy perspective? Local, at the local level, so at the health system level, what can we do at the state level? What can we do at the national level to help recognize the value and the burden of being a preceptor and move that forward? A lot of states are looking at some creative models. I'm part of the Utah Health Workforce Advisory Council, and we have a study underway right now about what are our preceptor needs in Utah. Interesting fun fact, at any given day, there are over 800 students across the health professions that have a need for a preceptor. That's huge. That is a lot of people. So there's a lot of work to be done in the policy arena to help with the education process and system that we're, and I'm actually kind of excited about that I think we're going to do some things that'll be creative and fun and help preceptors be recognized for the contribution they make.
That's awesome. I think it's incredibly important, right? I mean, that's an understatement. Last year, my colleagues from sister graduate programs were unable to meet some of their requirements for graduation due to preceptor shortages. I myself was very privileged. My program had a hospital that had plenty of preceptors, but it's hard to believe you're getting through all this education and here's this, what can we do? So it's exciting to working on that.
Yeah. Yeah.
There
are some things that can be done. It will cost money.
Yeah.
Stuff like that costs money, but I think it's time we stop saying that there's I think there's a balance of a professional obligation to pay it forward to the next generation and to smooth the way, but also to acknowledge that when you're precepting a person, you've just doubled your workload. So how do we acknowledge that? And we need to start thinking a little bit more creatively about how we work around that issue.
Oh, I'm excited to see more of that. My last two questions are, how does this science, what we've discussed, impact health outcomes?
Well, having nurses who carry with them a measure of cultural humility, so that they can walk into every situation where they deal with a patient and their family with open eyes and the ability to cross divides and to provide appropriate care in, I'm going to say compassionate. I might think empathy is overrated. I've got to be honest. I think it contributes to burnout. So in a compassionate way that meets their needs is so important. So the work that we're doing around helping nurse educators be more aware and able to teach in that way and to deal with cultural and racist events as they happen will help improve health outcomes, because the nurses we produce will be more, will have a stronger value and sense of cultural humility. So I think that's the first thing. The second thing is everything we can do to help health systems understand their accountability in keeping the nursing workforce healthy because it's not just we can't just say go be more resilient, go home and do some deep breathing today and you'll feel better. That is not going to solve the problems of violence in the workforce and burnout and suicide. I mean, we haven't even started talking about suicide, but all of the workforce issues. It's going to take a long time, but every step we can take to make that better is going to ensure a more stable and robust health workforce that can help people be healthier.
Well said, thank you. And then your last question with me, we've discussed compassion versus empathy as the provider, diversity among our healthcare staff, and then serving our populations through representation and allyship. I'm curious, given your work, if you're familiar, Maryland is doing a neighborhood nursing initiative.
Good for them.
It's really stellar. I bring this up because it is an interesting approach to our healthcare system, as it is removing sort of the burden of going to the hospital and providing locations within the community with nurses specifically, right? Neighborhood nursing. So I was curious if you had heard about that, or if not, how you think we can help change our healthcare system to benefit these communities we've discussed.
Yeah, so I was just thinking, I think I've talked for 35 minutes now, and I haven't said the word prevention yet. So thank you for bringing that up. So flipping our healthcare model to be from an illness-based model to a prevention-based model. Whoa, there's nirvana right there. Let's do that. Let's get that little job done. HRSA has had several demonstration projects. HRSA, the Health Resources Services Administration, they fund a whole bunch of, a lot of grants to improve health. They've had some demonstration projects for nurse-led clinics, for nurse home visiting projects, and every single one of them proves that community-based, no more than 10 minutes from your home, home-based, home environment-based healthcare is better and is preventative and has huge impacts. So there's a nurse visitation program that is based out of some work in Colorado that is working with first-time single moms who are teenagers and who have some risk factors. The nurse-led interventions with those families, following families for somewhere between 12 and 24 months, improves education outcomes for the kids that end up, high school graduation rates are higher, cigarette smoking rates are lower, drug use is down, crime is down, use of the juveniles. I mean, the impacts of providing care are well documented. We don't need to study this. We just need to do it. And we need to flip the switch on this. Several years ago, I was invited to Taiwan to talk about what public health nursing in the United States was like in Taiwan. And for me, I felt kind of like the largemouth frog, because what they're doing in Taiwan and South Korea and other countries with community-based nursing is amazing. Bachelor's prepared nurses running clinics in the community, controlling diabetes under protocol, policy-based kind of work, managing hypertension, managing diabetes, managing obesity, just really impacting the communities in a pretty inexpensive way. To be honest with you, prevention is a whole lot cheaper than the expensive hospital-based healthcare that we do, and there's a lot of opportunity there if we can just figure out how to get the payment system to pay for it, pay for that. for a while it's going to raise costs, but then eventually it would decrease costs. It's just that nobody's really interested in 10 years out. They're interested in 2 years out or 6 months out. So it's hard to show the cost benefit analysis of all of that in our current payment system.
Well, certainly some fun challenges ahead. And I really look forward to being a part of it. Thank you for answering all of my questions. I'll virtually pass the mic over to Kate for the last two now.
Thank you, Teresa. Thanks for providing a voice for so many issues that we just don't talk about a lot. I'm really grateful that I've even got to meet you today. This has been awesome. Okay, we're gonna wrap up this awesome interview that we need to broadcast to the world with one more question. Just to kind of summarize everything, what advice do you have for the next generation of nursing leaders?
Wow. Well, first of all, thank you for being the next generation of nursing leaders. I'm really excited to see what you will all do with our amazing profession. We stand on the shoulders of giants, and all I can say is reach up, reach out, and go for it. Don't make room for joy in your life. Don't skip out on that, because when you think about, okay, when I'm 65, 70, and I'm thinking about retiring, when you look back on your career, what will be the things that will have you will remember? Well, it's the things that brought you joy. It's the exciting things that happened. It's the fun things that happened. It's the interactions with patients. All of us have historical interactions with patients that just stay with us. So remember what it was about that's and why that interaction stayed with you. For me, it's a 72-year-old African-American woman living in a cockroach-filled apartment who needed a daily insulin injection back in the early 80s when I was a home care nurse. And she was kind, and she lived in horrible circumstances, and she was happy. So it was because she was living in her own home. So now I think about my 92-year-old mom, and what brings her joy? Well, she's living in her own home, doing her own thing. She's not dependent on too many people. She's dependent on me for a few things, but not very much. So, and she has joy in her life, and she leans into that joy. So don't let if it's not fun, don't do it. That's my advice.
Awesome. Thank you so much. Well, this has been a pleasure getting to know you and hearing about your career. And I can't even write down on paper all the things that you've done for the community and for the University of Utah. We're really grateful to have you. I'll turn the time just to Angie to close. Thank you so much for your time.
You're welcome.
Thanks.
Great questions.
Yeah, thanks again, Teresa. This has been so wonderful. And I know for me, you've given me a lot to think about and chew on, even at a deeper level than I was already aware of. So, and thanks for talking about hard things like racism. We need more brave people that are willing to do that. So thank you again.
You're very welcome. It's been a pleasure being with you this morning.